Uh, Good afternoon, colleagues, and thank you very much for the kind introduction. And many thanks to the organizers for giving me this opportunity to speak at this prestigious forum. So, in next 15 minutes or so, I will be talking about management of asthma and recent advances. I don't have any conflicts of interest. My talk will be mainly focusing on the recent changes in GINA guidelines and other important things like education, adherence, and inhaler techniques. As we all know, that salbutamol inhaler has been there since 1960s. It has been the king of inhalers due to its potent smooth muscle activity and relaxation. So every asthma patient knows about this blue inhaler. But this is the king, we want to get rid of it now. But how and why? So Sabina studies salbutamol use in asthma patients is a big cross-sectional study from 24 countries involving more than 8,000 patients. 17% of the patients were from Middle East. And what we found recently was that about 58.5% of the patients in Middle East were using more than 3 Saba canisters per annum, and 52% of the patients had poorly controlled or uncontrolled or partially controlled asthma. So there is a problem there. And we can see that you are allowed to use 1 to 2 Saba canisters per annum. But if you use more than that, for example, if you use 3 to 5 canisters per annum, your risk of exacerbations of asthma is 40%. If some patients are using more than 13 Saba canisters, their risk of exacerbation is 92%. So same medicine on which we have relied for many, many years is paradoxically is associated with adverse outcomes. Let me try to illustrate it with an example. So I saw this young, brilliant student from North Emirates. Last year I saw her, and she's 17-year-old. She has got childhood asthma, but she only uses salbutamol inhaler on as needed basis. She is not any inhaled corticosteroid. She has got typical symptoms of asthma. She keeps a cat, and she is allergic to it. She also has got symptoms of allergic rhinitis. She had 2 exacerbations of asthma in last 1 year requiring steroids. Her activities are limited due to asthma, hence she does not exercise or goes to gym. So when we analyze her parameters, her BMI is 38, and she has developed obstructive sleep apnea now. She is requiring CPAP. Her eosinophil count, total IgE, FeNO, everything is high. And look at this FEV1 of this 17-year-old girl is only 31.25% of predicted. I repeat it. FEV1 of this patient is 31.25% of predicted just for being on the wrong medicine. And this is a local Emirati girl who can afford all the medicines, basically. So there is a problem here. So taking all the evidence into account, we know about the side effects of Saba monotherapy for last 3 decades. But GINA came into action only in 2019 when they said enough is enough. We have got enough evidence that we should not be using salbutamol inhaler as monotherapy. So that is the main fundamental change in the GINA guidelines due to many things. But patients love salbutamol inhaler, rightly so, because it works within 2 to 3 minutes and it gives the quick relief to the patients. And then we were using salbutamol inhaler in 1960s, 70s, and in 1980s, people started knowing that these are the inhaled corticosteroids, which are the main treatment for asthma. And this is the data from Gothenburg, from Sweden. Then once they started using inhaled corticosteroids, the hospital days for asthma reduced dramatically. So there are some studies from Dr. Sousa from Montreal. He has again shown that more Saba you are using, there is a more risk of death. And more ICS you are using, it reduces the risk of death. So in 1980s, 1990s, many patients were dying of asthma. Their mortality has gone down thanks to the introduction of inhaled corticosteroids. But in this country, in UAE, we still have the problem of Saba overuse. Then came the long-acting beta agonists, or LABAs, in 1990s. And what they did is they attached the long chain with the salbutamol molecule and developed salmeterol or Cerivent. But we should not be using it on its own. It has to be used with ICS. And then came the synthetic form of formoterol. No, formoterol is a very good molecule. Why? Because it is both short-acting and long-acting. It will work as quickly as salbutamol within 2 to 3 minutes, and the effect of it lasts for about 12 hours. So hence, we are exploiting that character of formoterol more and more. So what happens when a patient comes to you with exacerbation? Usually on average, before the patients come to the ER, usually they are developing the symptoms of asthma for 3 to 5 days. And these blue arrows indicate that patient is using salbutamol inhaler. Salbutamol inhaler is sticky tape, actually. It is just dilating the airways for 2 to 3 hours, and then patients take another inhaler, another puff, until they hit the emergency department, and they are given gallons of steroids. So what we can do, this is the window of opportunity. That is where the patient has got very inflamed airways. Here we need to give inhaled corticosteroids. So if you combine inhaled corticosteroids with formoterol, you are achieving both effects. You are getting quicker relief due to its short rapid action. Also, you are treating the inflammation. Hence, there will be a reduction in exacerbation risk, and these patients may not come to the hospital at all. So when it comes to inhalers, please remember the different types of inhalers: PMDI, DPI, and Respimat. And the inhaler technique is very important. When we take the MDI inhaler, it has to be taken slow and deep. And dry powder inhalers has to be forceful inhalation. And Respimat I love this device, it's a very good device. The fumes last for about 1.2 seconds as compared to salbutamol, which lasts only 0.1 second when you press it. So you don't need that much coordination, but this device is not available for many medicines. So just remember, forceful inhalation for dry powder inhalers, slow and deep inhalation for MDIs. And combination of these ICS, LABA, and even LAMAs has led to about 230 different device combinations in Europe alone. Yeah. So different medicines have been combined into different devices, and we have about 230 inhaler devices in the market. So most commonly used here in UAE, I will say it is a budesonide plus formoterol inhaler or beclomethasone plus formoterol inhaler. These are our preferred choices when it comes to the patients with asthma, because both will contain formoterol. There is a problem with the inhaler technique. So patients, not only patients, also healthcare physicians, they don't know how to use inhalers properly. So this is the data from more than 6,000 healthcare physicians, and over 2 different periods, over a period of 40 years, they came to know that only 20% of the healthcare physicians know how to use inhalers properly, and they are not able to teach their patients. So when it comes to inhaler, I will take it as like you are driving a car. For car, you need a petrol, you need a good car, good engine, and you need a good driver. If driver is not good, you can drive Ferrari, you can put the best petrol in it, which is drug, but if driver does not know how to drive the car, you will not reach anywhere. So please concentrate on the inhaler technique when it comes to the patient. Almost every household in UAE has got a nebulizer machine at home. And many young patients, they don't want to use the inhalers. They want to use nebulizers all the time. They are bulky. It takes 10 to 15 minutes for one nebulizer to finish, while inhaler you can take within seconds, really. I have seen many patients having nebulizer machine and growing fungus in it as well and going into their lungs. They need proper cleaning, sanitization regularly. Also, particle size is very important. Many patients with asthma COPD have got small airway disease, which is the airways less than 2 micromillimeter in size. The particle size from usual nebulizer is usually 5 micron or more. Hence, you can give this nebulizer to the patients, but they will not reach the small airways. Hence, it brings me to the point that when patients are admitted with exacerbation of asthma, we do give them nebulizer, we do give them steroids, that's fine, but please don't stop their inhalers. Continue with their inhalers as well. That will take care of the small airways disease as well. And also, this will give you the opportunity to check the inhaler technique of the patient. What happens is, on the day of discharge of the patient, we start getting the inhalers. And most of the time, it has been shown in studies that 80% of the time patients are prescribed with inhaler without telling them how to use it. And hence they are using wrongly. I will recommend this website, asthma.org, inhaler videos. You put the name of the inhaler, it will give you the video, and I will show you. Please share it with your patients. To combat this effect of a poor technique and all those things, there are some new sensor devices or digital inhalers. They have been there for about 1 decade due to cost and some regulatory effects there. They have not come to the market. They will be coming in the future. What happens is you attach a chip to your inhaler that is attached to Bluetooth technology to the patient's smartphone and also the hospital dashboard. And these digital inhalers can do many things. They can remind the patient, please, this is the time to take it. You have not taken inhaler today. Please take it. Or if patient is taking wrongly, they can flash a red light you are taking, or they can even produce noises. Oh, Abdullah, you have taken the inhaler wrongly today. Please correct your inhaler. Or even if they forget their inhaler, where it is, you can press the button on your smartphone, find my inhaler, and it will start beeping. So this is something coming. And that for young patients who are very good in IT, I think this will be the solution in future. This takes me to the advances in asthma pathophysiology. Lung is unique because it is open to the environment, okay? And whatever lung disease we develop, it is an interaction of our genetic factors, how our genes are made, and environmental factors. And that will lead to different types of inflammation, immunity, and asthma phenotypes and endotypes. That is what we're talking about. All of us inhale about 11,000 liters of air every day, all of us. So when we inhale air, that air contains bacteria, viruses, pollutants, and pollens, all those things that will irritate the respiratory epithelium, leading to a cascade of inflammatory process, and that inflammatory process will lead to bronchoconstriction. So there are many interleukins we have identified over the last 3 decades, against which we have developed many treatments now. So the biomarkers to identify type 2 inflammation are simple. You take the blood test to check eosinophil count, full blood count, and IgE. And there is a pheno machine. It takes 2 minutes. Just to blow into the machine, it will tell you what pheno is. Then 88% of the patients express more than one elevated type 2 biomarker. And hence, it has led to the targeted treatment against these interleukins. We have got 6 biologics for management of severe asthma. And there is a recent study published at the beginning of this year. Even people have started using biologics, benralizumab, for eosinophilic asthma and COPD. Any patient who has got eosinophilia more than 300 cells come with exacerbation, you add benralizumab to them, and they had improved outcomes. It is not in the practice yet, but in future, instead of giving patient IV methylprednisolone or lots of prednisolone, etc., you may be giving biologics if the price of the biologics comes down. So biologics have got a role in the chronic management of severe asthma, but also in the acute management. Due to use of biologics, I take the analogy for rheumatoid arthritis. You don't see rheumatoid hands nowadays because the rheumatologists have done a very good job. They have treated these patients very well, started the treatment early. So through biologics use, we are talking about remission of asthma or even cure of asthma as well. And the 2 main changes, if you ask me, for GINA guidelines are, in the mild asthma, please don't use salbutamol monotherapy, use ICS, formoterol-containing inhaler. When it comes to severe asthma, don't use steroids anymore. Initiate the biologics early. There's a track 2 as well, but that is more difficult for the patient. I usually don't prefer that, in which you have to give the patient inhaled corticosteroids, plus they have to take another inhaler as a bronchodilator, which usually doesn't work here. So there have been significant improvements, and if you type the word asthma in PubMed, you will have a 250,000 of articles on asthma. And there's a problem. And there are some idiots around really who thinks that by giving teas, 7 different types of teas, as a bronchodilator, they can treat asthma. Okay, still people are drinking teas because tea contains caffeine and theophylline, which will provide bronchodilator effect similar to asthma. I have seen one patient with asthma who can't afford inhalers. He drinks 10 cups of kadak chai every day. That provides him bronchodilator effect. He keeps on going. But every month he comes to SKMC admitted with exacerbation. And I asked ChatGPT for these cough syrups, how much is the market value? $6.1 billion is spent on these cough syrups, which are useless. Okay, and these are just bronchodilators. They don't contain steroids. These are useless medicines. Please educate your patient. Don't use them. Many patients, I love my blue inhaler. Please try to remove this love from them. One patient 2 weeks ago admitted a young lady again. I said, okay, how is your asthma? What do you? She said, I use Predo. I didn't know what Predo is. I Googled it. Predo is a prednisolone syrup you can buy by 42.50 dirhams from online. And this patient was brilliant. He came after exacerbation from ED follow-up with me. He said, doctor, I want clenbuterol. He had searched it, or he had maybe getting from somewhere. I said, I searched it. It is a medicine which was used in 1970s before inhaled corticosteroid, but he is stuck that he wants this medicine. So in summary, the management of chronic airway disease, especially asthma, is 80% education, 20% medicine. You can provide these patients the best medicine. If they are not taking, they are not going to work. And every patient who has got asthma exacerbation, they have got a story behind it. Please try to find out why we are getting exacerbation. And the treatment of asthma is more of understanding the patient's perceptions. Some patient will say, yes, fine, I'm okay. One of my patients who used to play football as a forward, he developed asthma, he said, I'm a goalkeeper now. That's fine. That is the solution to it. But it's the perception, they accept it. We should not. And then they will develop obesity, obstructive sleep apnea, etc., etc. And we have gone very much forward in asthma treatment. There are so many targeted precision medicine-based treatments now, which can be given to these patients. One size does not fit all. Thank you very much for listening. I will be happy to answer any